Hello and welcome to Code Green Video Simulation. We begin this scenario with a patient who is a 26-year-old gravida 1, 38-week, 2 days. Height is 5 foot, weight is 70 kilograms, past medical history is significant for gestational diabetes and preeclampsia. Fetal distress was noted upstairs. Dr. Smith, the obstetrician, called a code green at 7:15. First to arrive was Dr. Smith, obstetrician, Meredith, SRNA, and Dr. Jones, the anesthesiologist. Anesthesiologist and CRNA are discussing our plan as we quickly get the room ready for the patient to arrive. The team is all here, including obstetrician, anesthesiologist, CRNA, anesthesia tech, labor and delivery charge nurse, patient's primary nurse, circulating nurse, NICU nurse, neonatologist, surgical technician. As they're coming into the door, Stephanie is discussing AMPLE, AMPLE, which stands for allergies, medications given, past medical history, last PO intake, solid and liquid, and explanation of events and situation. Stephanie has charted code green time, confirm that the correct consent is in the chart. Meredith and Stephanie verify patient information in the room. The patient is being moved with the help of a moving team from the stretcher to the OR bed. The CRNA Meredith has drawn up propofol and sucks as well as other emergency drugs that we're going to have available. Helpers are getting the patient attached to the monitor, but the priority is intubation. Patient begins to take 8 large breaths while Dr. Jones, the anesthesiologist, will be pushing our medications. The surgeon and surgical tech are scrubbed in, and Stephanie, the RN, is responsible for fetal surveillance, insertion of Foley catheter, and prepping the patient's abdomen and applying SCDs. They are quick to get the patient prepared for intubation. Anesthesiologist pushes 140 milligrams of prop and 70 of sucks holding cricoid pressure to prevent reflux and aspiration after the patient is no longer able to support the airway. DVL and uncomplicated intubation with a 6.5 ET tube. Surgeon is immediately notified once ET tube placement is verified. Condensation in the tube, positive end tidal CO2 on the monitor, bilateral breath sounds. Bilateral chest rise and fall, visualizing the ET tube go through the vocal cords, will turn on the volatile agent of choice and incision is made. Time of delivery to incision should be less than 3 minutes. It is now 7:33. Dr. Smith's made incision, and the baby is delivered at 7:35. Cord is clamped and Pitocin is started at 20 units in 1 liter normal saline to help the uterus contract and therefore reduce bleeding. Baby is managed by staff including NICU RN, nurse practitioner, neonatologist, respiratory therapist as necessary. Closure has begun. After closure and dressing is applied, fundal massage is implemented. SRNA Meredith has not begun emergence prior to fundal massage. After fundal massage, anesthetic emergence happens and the patient is extubated uneventfully. We will now turn and clean the patient. The patient will now be moved to the stretcher and transferred to the recovery area.